I'd like to talk to you today about the clinical application of cannabinoids and terpenes, or terpenoids, for chronic illnesses. Because I think that what people really want to know is how to actually dose. You know, you have this cannabis plants, what do you actually do with them? And what do you use them for which diseases? So I'll very, very, very quickly go through the basics. If by Sunday afternoon at a cannabis conference you don't know what the endocannabinoid system is, then really there's probably not much point in explaining it at this point. But anyway, within our bodies, we have this endogenous system that is the goal of the endocannabinoid system is homeostasis. It's to create a sort of balance or equilibrium within the body. And so the theories are, of course, that when you have imbalance or a lack of homeostasis in the body, that is when disease can occur. So the same way that you have all these other systems in your body, unfortunately, medical schools do not teach about the endocannabinoid system for the most part at this point, which is part of the big challenge that we have with the medical community, is they just don't understand it. They can tell you about the circulatory system, they can tell you about the nervous system, they can tell you about the gastrointestinal system, but they can't tell you about the endocannabinoid system because nobody bothered to tell them. Anyway, the same way that if you were not getting enough sunlight, for example, your doctor might prescribe for you to take vitamin D3 as a supplement. Your vitamin C levels are low, you might take vitamin C, you might eat oranges, you might take it as a supplement. It's the same thing with cannabis-based medicine. It is simply a phyto or a plant-based version of what your body produces on its own. If you don't have enough, you take it from an outside source, just like you would vitamin C or D3. It's really nothing much more sophisticated than that. There's been a whole lot of drama created around it and a lot of sexiness and a lot of other things, but it's really just giving you your body and a correct dose of cannabis. You don't really have to feel all that particularly altered if you have the correct amount, because if you keep in mind that homeostasis is the goal of cannabinoid therapy, then you only need to take it to the point where you have that. Now, we're not talking about serious things like cancer treatments and things, but in general, for most illnesses, you do not have to be greatly altered by it in order to have it successfully treat your diseases. Okay. So the next thing is, we may have heard a lot about terpenes or terpenoids. Terpenoids are simply terpenes in combination with other terpenes and other cannabinoids. They become these other forms that are just terpenoids. That's an oversimplification, but it's really enough to know. So no one's really talking about anything different when they're talking about terpenoids. They're just sounding more technical. Anyway, a couple examples you have of terpenes are alpha-pinene and limonene. Now, alpha-pinene is found in pine trees also, and it's also in many cannabis strains, especially in cannabis, in the more sativa-type cannabis strains. And then limonene, it's found in lemon rinds and in some strains of cannabis as well, also frequently shown in sativa. I'll tell you an interesting personal experience. I got on an airplane on an international flight recently, and I was exhausted and irritable, and it had been a bad travel day. And the first thing the flight attendant did was bring me a wet towel that was scented with lemon. And I put it up to my face, and I had this overwhelming calm and sense of well-being that came over me. And that's very much the same limonene that's in cannabis. So a lemon is a lemon is a lemon, wherever you find the benefits of it. Anyway, so down here are some of the more common ones we have is the alpha-pinene, like I mentioned, which also is from the pine trees. You have linalool, which is very effective as an analgesic, anti-anxiety, and it's found in lavender. You know, when you go get a massage, they have the room, it's all scented with lavender. We have these same components right in our cannabis plants. Beta-caryophyllene. Now, beta-caryophyllene is the most abundant in something called Ashanti pepper. It's black Ashanti pepper, white cannabis, and then black pepper and white pepper. So whenever the man at the restaurant comes around with the grinder asking if you want some pepper on your food, you say yes, please, because you will be, in fact, activating your CB2 receptor sites when you eat black pepper. Beta-caryophyllene is one of the only known substances outside of cannabis specifically that acts directly on the CB2 receptor sites without interfering with the uptake of the THC. So it's very, very helpful for that. So we look for strains that are very high in beta-caryophyllene, especially if we're dealing with diseases where there's a lot of CB2 receptor sites. Now, myrcene is found very often it's found in hops, but it's also found in mangoes. There's an old hippie trick of eating a mango before you get high to increase it. Well, what's really happening is the myrcene cuts through the blood-brain barrier and makes you have a higher uptake of the cannabinoids, which is why it makes you higher. And so you don't only have to use this. But it also has a very much of a sedative effect as well. You find it more in your indica-type strains, and I'll go into a little more about what those terms even mean in a minute. But myrcene is very, very helpful, especially when you're dealing with very, very serious chronic diseases. Then limonene, as I said, it's great for acid reflux. It's good as an anti-anxiety and antidepressant, and it's found in lemons. Now, let's talk about the importance of the entourage effect. This is a important comment that at the beginning, Stuart Smith, who is my partner in this, he says all the time, you just don't have any Marinol addicts. And the reason it is THC on its own feels pretty crappy. It is not a fun medicine. So it's not the THC that everybody wants. It's the THC in conjunction with the other cannabinoids and the other terpenes that have this entourage effect that we talk about that actually creates the various sensations. Because THC on its own is not very welcomed. Yes, and some people have some limited results with nausea and maybe going through chemotherapy, things like that. But for the most part, it is not a very pleasant substance on its own. It's far more effective when it's mixed with the other things. Now, right now we know we have about approximately 100, I read something different all the time, about 100 different cannabinoids and about 500 different terpenes. I have not run the math, but if you take how many possible combinations there are of those that can be in plants, it's close to infinite. It's a huge, huge number of different combinations we could have of cannabinoids and terpenes that each could be used medicinally in combinations for different things. So, whoops. Okay, sorry. So we already talked about myrcene and limonene here. Then it's also important to talk about some of the other major cannabinoids. They're considered more of the minor, only from the standpoint that tetrahydrocannabinol or THC and cannabidiol or CBD get all of the press and all of that people pay attention to. But more and more people are starting to understand the importance of some of the other major cannabinoids like CBG. Now, I also think part of this is market-driven. You know, there's a patent or somebody has, kind of cornered the market on CBD, like Sativex has been working on. So let's have somebody else that wants to do it with CBG. Well, CBG is the mother compound. All cannabinoids come from CBGA in a plant, and then into CBG as it decarboxylates. And then from there, CBG will become then THCA, CBDA, et cetera, through all the other cannabinoids. But it's also very, very good for pain relief, and it works when you take THC in combination with CBG, you have a better analgesic effect than you do when it's on its own. CBN, which is what THC degrades to, for anybody who's had any cannabis laying around, they left it out, sitting in the sunlight for an extended period of time, you'll see that the next time you go to smoke it, it makes you a little bit sleepier, and that's because of the degradation of the THC into CBN. Sometimes we push CBN, or we want to have CBN, so that we can make medicines that are used more for sleep or more for nighttime, much more somnolent effect on them. It also is great for pain relief. And then, of course, CBD is a CB1 and CB2 antagonist, but when combined with THC, makes it far more effective. See here what I'm saying right now, we also have like 5,700. Of course, that was last week. It's probably 7,000 this week. And every time I go to seedfinder.eu, I'm just shocked at how many more strains there are. Just have to look out here at all the geneticists and all the seed breeders out there. You know, we started out with 100 strains, and now there's 6,000 strains. So what is a strain? You start out, like I said, with the landrace strains, and these were the original ones that grew out in the wild. You had Acapulco Gold, you had Panama Red, you had Afghani, you have all of these strains that were actually the ones that grew there, God-given, however, whatever you believe, the plants were just there in nature. One of the things that we've been collecting on in our research is we ask people where they are from as far as what their ethnic heritage is, because we're looking for patterns to see if there's certain particular cannabinoid and terpene combinations that come from breeds that have been developed from particular land races, to see if there's more of a propensity for those to work in certain areas over others. For example, when I'm dealing with there's certain groups of Asian Americans that if we're working with things, I know it doesn't sound directly related, but from some of the Afghani strains will be more effective. If I'm dealing with some that come from, we have a lot of people from Mexico and South America in the United States, and a lot of times the strains that they use will be much more effective with them that'll come from strains that are from like Panama Red derivatives and things like that. Now the hybrids are all these different combinations where geneticists are looking to create, you know, whether they're motivated by wanting to have a patentable, one-of-a-kind, their own strain, or just because they're looking for superior genetics. When I was growing up, the cannabis was so weak compared to what it is now. When I first was reintroduced to cannabis after being away from it for decades, I was shocked at how little I had to use to achieve the same results, and that's as a result of all this major breeding and breeding out some of the inferior and increasing the THC levels. I mean, you're finding we have flowers that come to us right now that might have 33% THC or THCA within the flower itself, where in the past maybe it would have had 3, 5, 7% THC. So to an inexperienced user, that can be quite significant. So it's important to know what's in the medicine, because maybe taking that second puff might be too much. Okay. Indica and sativa, there's not really, indica is kind of a nebulous term these days because of all the different breeding programs that are out there. So we say things like Afghanica and things, strains like that, more than we use the indica. But for this purposes, we're simply talking about the differences in the type of plants and the type of terpenes that we're usually going to see resident within these. Indica plants tend to be smaller, bushier, thicker, where your sativas are going to be more spindly, narrow leaves. They actually, I think I have a slide in here that shows the examples. Now, interestingly, most of the high CBD plants seem to be bred from sativa plants originally. So like AC/DC, which is a very, very successfully standardized and stabilized strain that's very popular, especially in like California where I'm from, is a sativa-based strain. Blue Dream, which is a high sativa dominant, even though it has a little bit of a somnolence because of the blueberry that it was bred with, it still is considered, like for somebody like me who's very sensitive to sativas, if I take it, it's going to make me feel like I have heart palpitations, like it's jumping out of my skin. Granddaddy Purple is a very high THC strain, but it's also very good for relaxing and used. We use that a lot with cancer patients. Okay. So activation of the CB1 receptor sites, CB2 receptor sites promotes homeostasis within the body. I'm not going to go through this right now. I've already seen just about this same slide somebody else had up yesterday, showing how the majority of the CB1 receptor sites are within the red and within the central nervous system, and the CB2 is more in the immune and throughout the rest of the body. So the THC acts as a lock to go in and activate the receptor sites, whereas the CBD we're not really sure exactly how it acts on them. That's why we have research that needs to be done and has been done to understand more and more about it. But we do know that it is a antagonist, so that if you've taken too much THC, you can take some CBD and it'll bring you down. Okay. So let's take a look at, there's a lot of talk around THC and cancer, or CBD and cannabis in general and cancer. So what's happening in this situation is you have your CB1 or CB2 receptor sites, which is indicated by this squiggly line here. You have your cannabinoids that have the key is fit into the lock and it's activated the receptor site, which starts this entire chemical cascade that goes through here. It's like anyone that's ever played dominoes or done one of those things at the fair where you watch where it goes. You don't need to know what's happening along the way. That's way outside my pay grade. But at the end of it all, you have what's the important part, and that is this right here, which is apoptosis, or programmed cell death. You know, you really want to make sure that if you take this slide with you if you're going to see your oncologist, and help them to understand that there really is medical science and understanding around what's precisely is happening when you use cannabinoids in conjunction with other therapies to kill programmed cell death. The other thing is the difference in the way that apoptosis works versus chemotherapy drug or something like that they have to watch how the speed at which they kill cancer cells when they use chemical therapies and radiations, because there can be so much toxicity in the body from all these dead cells. Well, with apoptosis, you don't have that. The cancer cells, I'm not qualified to go into the complete explanation of the what and why, but the cancer cell just either just goes away and is replaced then with just healthier cells. Okay. Now, CBD, Dr. Sean McAllister has done a lot of work around something called the ID1 gene. And the ID1 gene, when it's present in infants, and when you're born, that's a good thing, but you don't want it to be present later on, because what it is that it's involved in the proliferation and metastasization of cells. So on certain types of cancers, there's a higher levels of ID1 gene. And what we have found is that CBD, cannabidiol, does a very good job of interfering with the translation of the ID1 gene and keeping it from causing more cell proliferation and spreading of those cells. Now, these are very loose and not very specific in an explanation of, like, you can say, oh, if you have this, then treat with that. But we do know so far that if you look, you'll find that the cancers that are most readily associated with presence of the ID1 gene, this is the list here that you have. Now, the importance of this, why you would care, is somebody who's going to use cannabis medicinally, is because if you have, for example, breast cancer or hepatic carcinoma, you can start out with a much higher level of CBD and a lower level of THC than you can on different types of cancers, because the first thing you can do is you can block the cells from proliferating and block the cells from metastasizing, the same time that you can use a much smaller amount of THC to get in there and cause the chemical cascade resulting in apoptosis. So this allows people to use much, much lower levels. You know, you'll hear about people that, you know, there's the methods out there of the one size fits all. You take a gram a day, and it works for some and it doesn't work for others. Well, there's very good reasons why it doesn't work for some and it works for others. And my theory is that this is a very big part of that. Okay. Now, one of the things that we've been doing is we've been tracking for many years what the way that my practice works is a patient comes to us, they fill out a extraordinarily extensive patient intake form. It's very rigorous. It's about 13 pages long now. It started out at 8, and it keeps getting longer because we keep realizing that there's more questions that we need to ask. So we've been getting this information about them, and based upon their intake, we are then able to make a determination of a starting point, not a definite, not going to end up there necessarily, but a starting point on what their dose should be, their dose goal should be. Also, what sorts of cannabinoids and terpenoids that they're going to need and which particular strains are going to be most effective for them. In this case here, we're dealing with glioblastoma brain tumors. And I'm showing, working from the bottom up, I'm going to show you the largest doses. And the other thing that we've found is that where doctors in traditional medicine have a tendency to want to say how many milligrams per kilogram when they're dosing, we have found that it has a far greater correlation with the age of the patient than it does the weight of the patient. Right? Our youngest patients take the largest amounts of cannabinoids. The oldest patients take the least amount of cannabinoids. So in this case, she was 2 when she came to us, and now she's 4. She came to us initially for palliative care because she had such excruciating pain from her astrocytoma, which is a form of glioblastoma, by the way. And so we started her out, and lo and behold, immediately there started being cell death. So we said, let's just go for it, and let's see if we can kill it. Well, now there's a little bit of necrosis they're seeing, but without doing a biopsy, they won't be able to tell for sure. But so far, they don't see anything, and she just started school, something that this family never thought she would be around to do. She was taking 400 milligrams of THC and 350 milligrams of CBD each day. Now, just to put that into terms of what that means as far as a dose, if you're dealing with a gram of cannabis extract oil, you can expect it to, and it's extracted with ethanol because we do all of our extractions with 190 ethanol. You could expect there to be somewhere between 50 and 75% realistically of THC within, assuming it's a high THC strain, of course. But you're going to expect it to be somewhere between 500 and 750 milligrams of THC per gram. So in this case, she was taking about a little over half a gram of THC and one little over half a gram of CBD. This female at this age, at 28, she was at 200 milligrams and 100 milligrams. By the way, we standardize. We always put the THC first and the CBD second so that when you are talking about it, there's an accepted nomenclature so that you know. You don't have to say, if somebody says, oh, yeah, I'm taking 100 to 200, I might assume they're taking 100 THC and 200 CBD. So we try to get people to standardize saying always the THC first. So without going through all these, all the way getting up to here to an 88-year-old man who was successful with treating and eliminating any signs of his glioblastoma with just 75 milligrams of THC and 30 milligrams of CBD a day. As you can see, there's a quite significant difference in what happens on the strains and on the ages. Breast cancers. Also, there's quite a bit of difference here. Now, these ones, too, at the asterisk at the bottom, I'm not sure what happened to my note, but that was that they were actually only interested in treating the side effects from chemotherapy. So they were not looking at actually treating the disease itself. Now, one of the things that we do is we ask, there's 5 particular questions that are the most important that you can ask, that you know somebody. Besides knowing what their diagnosis is, to know what their present cannabis use is, or their experience with cannabis, know what pharmaceuticals and nutraceuticals that they're on, because you need to know what runs through the cytochrome P450, because it'll make the other pharmaceuticals much stronger if they go through that pathway. Know their age. We have to know their age. And then the last and most important thing is, what is your objective? What are you trying to accomplish? Because as a practitioner, as a caregiver, we might have a very different goal for a patient than they have for themselves. Or they may just want to feel better. They're not worried about living or trying to be unconscious or do something else while they're trying to kill the cancer cells. They may just want to get rid of nausea or get rid of headache or whatever. And so you have to be very respectful of what the desires and the dreams are of the actual patients. Now, epilepsy is very complex, and when I get a new epilepsy patient, I'm always a little bit nervous because epilepsy is a symptom of many, many, many different diseases. And so to say that you're treating epilepsy is a bit of a misnomer. It's like saying treating pain. Well, what's the pain from? Where's the pain caused from? Is it, somebody might be having seizures as a result of having a brain tumor that they removed and it acted something in the brain. They may have it from a car accident. They might have it because they have Dravet or Lennox-Gastaut syndrome or something like that. And each one of those are slightly different in the treatment. Many, many times with epilepsy, we also include THCA, because there's also a lot of times there's inflammation and intestinal issues that can lead to, that's like there's these things like the GAPS diet and things that are important to include when you're looking at treating these diseases. It is a mind, body, spirit. It has to include diet. It has to include lifestyle changes as well. Anytime you're treating any kind of disease, you can't just give somebody cannabis and have them keep doing with everything else they've been doing and expect to have much of a lasting change. But in epilepsy in particular, you have the activation of the CB1 receptor sites, which shorts out the calcium ion pump in presynaptic neurons, okay? So you hear a lot of this, especially with all the Charlotte's Web and things like that, where people think that, you just have to give CBD. Well, even Charlotte's Web isn't Charlotte's Web anymore. It started out being basically a variant of R4 or ACDC of a cannabis-based CBD, and now they're doing it from hemp. Well, they've done it so that they can have it in all these other countries where THC is not allowed. Well, the problem is, without a little bit of THC, these kids are going back to having seizures. You've got to have a little bit of THC. That's why the isolates don't work on their own. And then here's an example of a 7-year-old little girl where she was able to take only 10.3 milligrams of THC along with the 250 milligrams of the CBD. And 10.3 might not sound like much, but if you don't have that, she'd be back to having seizures. It is very, very important. There are some people, as much as 1/3 of a milligram of THC is just enough to activate the cannabinoid receptor sites to take them back into a state of homeostasis or to help them achieve whatever it is their objective is. So 10 milligrams is actually quite significant. You're not going to get that from smoking. You're going to get a lot more than that. But like I said, we're looking for the goal outcome of being homeostasis, not getting high. So we're not interested in people feeling the medicine. We just want to eliminate what their problems are so that they go back to be normal, to be neutral. Now here is intractable nerve pain. There's 5 mechanisms involved, okay? It retards the electrochemical reactions of the peripheral brain receptors, interrupts pain signal at the dorsal root ganglion, interrupts the pain signal at the neuron, and activates the CB2 at the leukocytes, provides major anti-inflammatory response, and then psychoactive euphoric effect and short-term memory reduction, mitigated stress response to pain. I know that's a big mouthful, right? But, people say, I don't know why it works, it just does. Well, we do know why it works. This is it. This is why it works on pain. CBD, of course, has anti-inflammatory mechanisms that with all disease, you're going to have inflammation because that's how the body goes to fight the areas where there's dis-ease. And so as an anti-inflammatory that's far, far more powerful than a steroid, having CBD in your toolbox is extremely important when you're dealing with chronic pain. In this case, I'm going to show you the actual dosing for this woman, the 78-year-old female. When she came to us, She had intractable nerve pain. She had not slept through the night in over 20 years. She was suicidal because she did not see how she could possibly go on like this anymore. So I know this is a lot of numbers and it's hard to read, and I apologize. I'm not much on the slides. So the first thing that we gave her was Swiss Gold. Now, this was a high CBD strain, and it had this happened to be infused into olive oil, so it's not going to be like an extract. Because when you're dealing with something where you want to get a very specific, precise dose, and you're dealing with very small numbers of cannabinoids, you need to have them in a form that people can measure accurately. If you're dealing with something that has 700 milligrams per gram, how are you going to identify the difference between 2 milligrams and 3 milligrams? It's almost impossible. Our scales are just not that sensitive, even with us requiring our patients to use a scale that goes to 0.001. It's still not sensitive enough. So this helps to infuse it into oil, and that way a person can have consistent dosing over time. So in this case, we wanted her to have 3 doses a day with 15 milligrams of the CBD. Within the Swiss Gold itself, because it had 0.07% THC in it as well within the tincture, or the infused oil, by taking the 15 milligrams here 3 times a day, 15 milligrams per day in 3 doses. So it'd be 3 doses of 5 milligrams, or perhaps one of just 1 or 2 milligrams, a little bit of the more, and making sure that throughout the day. Sometimes they take more at night, more in the morning, whatever, but this is the goal for the day. She still got through that a residual of 1.5 milligrams of THC. So she was getting a little bit of it there. We introduced a second medicine. The names don't mean anything. This is the only thing that means something to me right here, and that's this number, that's my lab test. That's what shows that I know exactly what's in this medicine to the best of our current lab technology. Is every medicine is traceable back to a standardized lab test that measures cannabinoids and terpenoids within the medicine. So in this particular one, I was looking to give her THCA. I was looking for the anti-inflammatory effects of THCA and also the fact that it lends itself to the overall well-being. So I wanted to give her 15 milligrams of that. There was a little bit of CBD within this particular OG2 times S medicine. And so she was able, when she got the 15 milligrams in one dose, it had such a small amount that it wasn't even measurable of what the CBD was. But then when I came over here also to look at the residual of the THC, I needed to take into account she was to do that same, this is all the same medicine, by the way, that she was going to get 3.8 milligrams of the THC in here, and then showing with the CBD. The reason that's important to do this is if our initial goal, can I go backwards? How do I go backwards? Here, okay, thank you. Because if you look here, the goal was to have her have 15 milligrams of THCA, 5 milligrams of THC, and 15 milligrams of CBD. I needed to be able to get that with the combinations, taking into account the cannabinoids that are going to be coming from one source or another. So as you see here, there was a 1.5 milligrams that came from here. I had to get her the rest of it somewhere else. So I was able to get her the rest of it in this THCA strain, which is 3.8. So it equals just about a total. So it's little over 5 milligrams, 5 and change, that she ended up with. The point is, you can take a whole plant medicine, a whole plant extract, infused, whatever, and you can get down to the most minute and specific numbers of cannabinoids. So, and this is what your doctor wants to see. This is what your doctor wants to hear, and this is when your doctor's going to understand that you're actually using this as a medicine and not just rolling the dice. I like to say the difference between what we do and what most people do is they go to they used to call it a Skittles party, where people would come and they would raid their parents' medicine cabinets and they would throw all the drugs in a bowl and people would go and they would take and they would have a party. Then you had kids overdosing beyond, heart medicine and birth control pills and mommy's little helpers, and it was horrible. And a lot of times you see the disasters you're seeing are people that are treating this like a Skittles party instead of like a readily dosable medicine. Unfortunately, you have to have testing labs. And one of the big things that seems to be lagging across the world is testing labs. And if I was going to be an evangelist for anything, it would be for the fact that we have to have accurate testing across the globe, where you can't buy a higher THC number by paying more to a lab, or they actually know how to clean their machines in between different tests so that things are accurate. I mean, there has to be better standards on that, because people like me depend upon those numbers to make dosing decisions. And at the end of the day, if you have a patient that's extraordinarily sensitive, they're going to suffer if we don't have the right information. Okay, now here it is for insomnia. You can read through. The way it works for it is that obviously you're going to want to use strains that are higher in the myrcene, like we talked about before, that break through the blood-brain barrier and have a very calming, somnolent effect. And then also higher CBN. Like I said, you can push the CBN with time and sunlight in order to, and one of the things about you take this year's harvest and take a little bit and set it aside and don't store it quite so well, don't do such a good job, and that way you can have more CBN next year when you're going, or later on when you're going to make medicines for nighttime or for sleep. So in this case, it was a 60-year-old male, and we were just giving him the straight Granddaddy Purple. He was taking 25 milligrams and sleeping like a baby. Okay, hypertension activates the CB1 and CB2 receptor sites, and then vasodilation of blood vessels, lowering blood pressure, cause relief of stress by blocking production of acetylcholine within the brain, and slows down the neurotransmission at the synaptic cleft. So one of the things the reasons that THC works so well for people with PTSD is because of this interference with the acetylcholine in the brain. That is what causes short-term memory, or helps with our short-term memory. And, if I don't know about anyone that's ever smoked a lot of pot, you get, you're smoking it, and then all of a sudden you start a sentence and you can't get to the end of your sentence. You can't remember what you were saying. That's the interference with the acetylcholine. You can take a supplement called citicoline, which is readily available from Jarrows and other companies. I'm sure there would be somewhere over here where you could get citicoline. I just absolutely do not recommend it for cancer patients because of the vasodilation. You don't want to have that with cancer cells, so you don't want to give the citicoline in that case. But in here, what we're dealing with is when one of the reasons, I think that Dr. Meshulam, I can't remember the exact quote, but he said one of the gifts of THC is the ability to forget. And when you have like a vet, for example, that's at PTSD, what's really happening is they're in a continuous state of fight or flight. Like the saber-toothed tiger is chasing them, and that's why we have that in our brain, so that we know when we're under attack to fight. Well, with PTSD, you just kind of stay in that case. Some people with hypertension, depending on what the causes are and everything else, you got a little bit of the same sort of situation, is where you got to get them out of that fight or flight sort of mode. And THC is just beautiful at doing that. This guy started out with 30 milligrams of THC, and he was at 13 of CBD per day on infused olive oil. Now I want to show you an interesting, and like I say, I hope you can follow my bad pictures, but I want to show you how we were able to recreate this over and over again. Initially, we had him on this strain here, and it was his initial dose of the 30 milligrams a day of the THC, and that, because of what was in this particular strain itself, that gave him 13 milligrams of CBD. And he was doing one dose at night before bed, and he had beautiful response. He was able to. This was a man that was only 57 years old, and he was going to be enforced into disability retirement because his blood pressure was so bad, and he was on so many medications that were not working. He's still at work. He's been a patient of mine now since middle of 2011, and he's still actively at work. He's still doing great. He's off of most of the medications. He still is on one or two other medications, but compared to where he was, it's quite phenomenal. So after we ran out of this one, and we didn't have any more cotton candy diesel, because that's the nature of cannabis, is every time you get a new plant, even if it is the same plant, even if it is standardized, there's going to be variance in it. And because we are not our own growers, we don't have a vertical integrated supply, sometimes we have to wait for whatever one of our growers grows for us. Now we've moved more to standardization, but back then. So I had to figure out how to get him this dose with what I had at the time. And at the time I had cookies, which is a derivative of Girl Scout cookies, and AC/DC. I was able to mix the different, compound it in such a way where I could recreate by using it's just mathematics. It's just math and a little chemistry. By putting together a little bit of the cookies and the AC/DC, I was able to reproduce for him precisely the 30 milligrams, and in this case 15. So we got 2 more milligrams of CBD, which is quite inconsequential when you're dealing with CBD. And he still had the 1 dose a day. So he still was able to have that same uninterrupted success and experience with his medicine, reliable dosing, just like he had from the first one. It wasn't like playing Skittles or having to start from scratch. It may take a day or so before you feel exactly like you did before, but if anyone who wears glasses and has ever gotten their new prescription, even though it feels great, it might take an hour or 2 before you adjust to seeing through them quite as naturally. We then, the third time, had to do it using Pepe Le Pew and Swiss Gold. As you can see, totally different numbers on the percentages that were on the actual medicine, but we were able to mix them in such a way where he got his 30 milligrams of THC and 15 of CBD exactly the same way. First case, he knew how much to take. Second case, he knew that his daily dose would be these 2 mixed together. And then here, this much was the actual dose that he took to accomplish it. Irritable bowel, Crohn's disease. Now this one is a little bit more complicated. These people tend to do really, really well with inhaled THC. They still need systemic, absolutely 100%. We talk about having a little bit of CBD for the inflammation, so they take it internally. This woman here, I had her on 30 milligrams of THC and 15 milligrams of CBD. She was able to use them systemically and control her symptoms and have great relief. She wasn't running to the bathroom. She was able to go to work. She had been working for months out of her house because she couldn't make it to the bathroom in time from her desk to the restroom. So she was having to work. And then she was able to go back to work and be much more productive. I have another Crohn's patient who has a lot of, like you said here, where it talks about tendency towards abscesses. He has a fistula that just won't heal. So we've been doing part of the CBD in the form of a suppository at the same time that he's taking some of the CBD and THC sublingually in the form of an extract, and if he has breakthrough pain or breakthrough symptoms, he can just take a couple of puffs off a vaporizer of the same exact extract that he's taking, and he's fully functional again. PTSD, ADHD, Tourette's, we talked about how that works before. It's a 50-year-old female, 15 milligrams and 5 milligrams. So as you can see, these are nowhere near the types of doses that people that talk about a gram a day or 1 of anything, these are quite small amounts for people to still be fully functional and to have incredible medical results from the medicine. So what I'd like to say here is that, in conclusion, cannabis is greater than the sum of its parts. Isolates are not the same. If you don't have the entourage effect, you do not get the full benefit of cannabis. The endo and exo, or phytocannabinoids, play a significant role in treating almost all diseases. All diseases you have, if there is disease in the body, there is a lack of balance in the body. If there's lack of balance, there's not homeostasis. Cannabis is designed to achieve, or the endocannabinoid system is designed to achieve homeostasis. If the body is endocannabinoid deficient, you use phytocannabinoids. It's that straightforward. Doesn't mean it's going to cure everything. It doesn't mean everything's going to go away, but it's certainly going to make a significant difference in your outcomes when you're including all of the systems in your healing. It's also important to select the right strains. If somebody who has PTSD uses a sativa, and of course, this is a generalization. It's not the case with all, because sometimes the exact opposite. They use a high sativa that has alpha-pinene in it. It's going to be very calming. The same way that Ritalin given to somebody with ADHD, it's very calming. Somebody who doesn't have that will be very stressed out by it. For a vet, it's perfect. Somebody that has sleep problems, you're not going to give them a sativa. You're going to give them more of the indica-type strains. It's also possible to dose correctly and consistently. I think we've shown that. You can have individualized treatment plans for patients. Separating the THC and CBD doses, I didn't really go into this, but we separate them out by 2 hours whenever possible, because CBD is an antagonist for the CB1 receptor sites, and THC is an agonist. So we don't want them working against each other, and we feel that we've been successful in keeping the doses much lower by dosing them separately. And when I say that THC and CBD, I'm talking about dominant strains. Obviously, we're talking about whole plant here. And then all cannabis, and I should have all this in capitalized bright purple, that all cannabis must be lab tested to guarantee the outcomes that we're looking for. And without THC, most diseases would not be treatable with cannabis. So I'm quite disturbed by what I see, the worldwide trend of CBD-only legalization, because it's leaving the vast majority of all diseases untreated, which is really a human rights violation for so many people not having equal access to care. So, and then I'd like to show you, here is our team out on a celebration one night, so we're all a little casual here, but here you've got, many of you might know who Justin Kander is. He's written several books on the endocannabinoid system and cancer. He's just fantastic, and he has now come to work with us, and we're very happy to have him. There's another individual who's not here, and then Kira, anyone that contacts us, she's our patient advocate, and she's just amazing. Bianca Javog's family did the Canacosta in Costa Rica, and she came and interned with us and has now gone back to Costa Rica taking that knowledge with her. Our lab chemist, who's looking quite professional here, Jeff, Stewart Smith, Lori Hernandez, and then, of course, myself. Thank you very much. Okay, sure. If anybody has any questions, I'm happy to address them. Yes. Oh, well, okay.
Hi. Do you see a gender issue with high doses of CBD in your work? Like women react differently than men to
CBD or
yes.
to all cannabis?
No, to CBD.
CBD.
Yeah.
It's interesting you should ask that, because I don't think that there's a gender issue. I think that it's one of the fun things that I don't know yet, and I'm collecting the data to find out. My background, by the way, is I'm a process engineer, so I'm a data junkie. And I've actually built software around this so that we can figure all this out. One of three things is going to happen with CBD. It's either going to make you feel very invigorated, very energized. It's going to make you feel very sleepy, or you're not going to feel anything. And at this point right now, even though I've treated hundreds of people, we don't know enough yet to know who's going to be which. I do have a theory on it that people that like the sativas, the more of the higher alpha-pinene type strains and limonene strains, those people tend to be much sleepier as a result of using CBD than people that like the higher indica strains. Right now, it is simply a theory, but I've not seen a gender relationship with it.
Eliza Walczak, Project Phoenix, Poland. I have a question related to Boaz Bechtel's question about patients who react reversibly to a cannabinoids profile. Can you talk a little bit about that?
Could you expand on what you mean by opposite?
Sativa work for them differently than for most of the people, and indica work differently, and also other cannabinoids like CBD make them high, THC not.
Right. Well, those are two different things. Let me go with the first one. You had mentioned something in your talk before that was, a lot of our experience has been that people that are not able to adjust to cannabis are because they're not willing and able to let go. They have this fear and this need to control. And part of the negative or adverse reactions that we can experience with cannabis are people who are afraid of just experiencing what's going to happen without being able to, I don't know, it's something that's foreign to me, but it didn't used to be. I used to be one of those people. I couldn't stand cannabis. I hated the way it made me feel. I hated everything about it. I couldn't understand why anybody would ever want to use this horrible drug. Until I took 2 puffs once when I was in about a level 9 pain, and my pain went down to about a 2. And I was like, okay, there's something here. Well, the next time I did it, I took about 4 puffs, and that was way too much. And I went into that whole paranoid, horrible, miserable feeling and everybody had gone to bed, and I was all alone, and I was scared. And then I thought, you know what? There's millions of people that are using this and love it. I'm going to just pay attention. I'm just going to observe and pay attention without judgment and see what's going on and just meditate and just go with it. And it was transformative, and I never have had a negative experience since. If I have used a cannabis strain that didn't agree with me, I know it's the cannabis and it's not me. And there's an ability to separate out from the drug and its effect from me, I don't even know how to articulate it, is an incredible freedom. People who have PTSD, ADHD, ADD, a series of other Tourette's, they will often respond the exact opposite of what others would to the same exact strains. I give sativa, and part of the reason for that is the difference in the acetylcholine in the brain. Taking the person, that short-term memory loss, takes a person out of the fight or flight, and it's very calming. The same way that Ritalin, which is a speed, will make them feel mellow. Yeah. Now on the CBD, just don't know enough. Yeah. I'm freezing.
I'm curious. In my work, I've seen this in rare instances, but there are some people that are allergic to indica strains and not sativa strains, and vice versa. Do you have some commentary on that?
Yeah. They're allergic. Oftentimes what you're seeing is there's a prevalent terpene within those strains that the people like. For example, I'm very allergic to alpha-pinene. And so strains that have alpha-pinene in it make me very sick. That one of the things I saw here, and I was going to suggest, is that you have people wear masks when they're trimming, because that can also be an issue that can cause, yeah.
The other side of this, I just wanted to expand a little bit. There was one individual I had personal experience with who could rub it on her skin, and because she was allergic to one variety, and she would know just by rubbing it on her skin which variety not to use as medicine. Right,
absolutely. Absolutely. Yeah, that's one of the reasons that it's important to lab test, so that we can find out what cannabinoids and terpenoids are in there, so that people know which ones to avoid as much as which ones to have. Yeah.
Is the reaction to the terpenoids?
Yes.
Okay.
Like, for example, I can't have anything that has pine at all, or anything that has colophony, which is the yellow sticky, because that also, by the way, just so you know, I have pages and pages and pages of references. So if anybody wants, I'm happy to share them with them. But yeah, it's the same reason that you can't have all plants and all foods, and people have all sorts of allergies. And like we looked at with the terpenes before, they appear in lots of other things. And those might be the ones that you can't eat those foods or use other things that have those products in them as well. Yeah. What else? So cold. Freezing.
Hi, thank you. I was wondering, you've been talking very nicely about terpenes, but I would like you to highlight what's the best method to keep such a volatile compounds for patients. So, for example, would you recommend something like juicing, or rather than doing tinctures? Like, what's the best method to keep terpenes? Because it's quite a matter when we do extracts and so on.
That's a very, very good question. Solvents are selective strippers. Each one's going to strip something else. The reason some groups like butane is because it strips THC very well. I personally wouldn't use anything. I don't even use, PAM on my food. I wouldn't use butane in my medicine. If you infuse oils correctly and you are careful to decarboxylate, oh, God, thank you. I love you guys. I'm so cold. Sorry, I'm from California. I don't know if that has anything to do with it, but yeah. When you infuse directly, and if you make sure that you keep your temperatures at such a way that you're decarboxylating to drop off the acid molecules, you're going to do the best job of keeping the original profile of the plant. The problem is you lose so much because it doesn't take up so much of it. Now, we've been working on methods for years on doing the ethanol extractions, and we've got it down to pretty much of an art form that we're able to maintain the same profile that we have in the flowers into the extracts. But it's very, very difficult to do that. It's extremely difficult. I would say stay away from all toxic solvents, hexane, butane, any of those. ISO, my God, stay away from all of those, and stick with the ones that are at least organic in them. And if you keep your temperatures right and you keep your times right, and it takes some time to figure that out, then you can do a pretty good job of keeping the profile. There's no perfect way to do it. I wish there was. I see some people that are like, some organizations are doing what I call Frankenstein medicine, which is where they're adding back in these artificial, from China, these terpenes, artificial terpenes and all, to recreate profiles, and they're calling them medicine with full profiles. But the reality is the cannabis plant was designed in such a way perfectly. It's a perfect design, and it's perfect design that when it's heated, and it's heated correctly, it's going to transform it to exactly what it's supposed to be. The same way that when you smoke it, you get just a very brief amount of the terpenes that come from that, but you're getting exactly the amount you're supposed to be getting. So I wouldn't be that concerned about it as long as you're using healthy methods and correct temperatures and times. Yeah. Anybody else?
How precise do you have to be in your work? I will explain. Let's say that 15 milligrams of whatever is good for a given patient. Is it possible that it will turn out that 14 is not enough and 16 is too much, or it's not that accurate?
That's a very good question. It all depends. It depends on the person. It depends what you're treating. I mean, when we're giving somebody 400 milligrams of THC, I would guess that the reality is sometimes they have 390, sometimes they have 420. I mean, even though we try to be exact. But when you're dealing with somebody who has that's very, very hypersensitive, 1 milligram might be all the difference in the world. We standardize as close as you can do with the full plant are infused at approximately 10 milligrams per mil. So what that means is, and since they're infused into olive oil, and we've done the measures, you have between 28 and 30 drops per mil. Okay, actual drops. You sit and count them. That's how many times it takes to get a milliliter of oil. So that means that each drop is going to be about 1/3 of a milligram. I might have an initial goal for a patient of 5 milligrams. They may never get up to 1 milligram before they've achieved what they need to from the medicine. So in their case, if it's 1 or 2 off, it can be all the difference between success and failure. When you're dealing with your higher and you're dealing with, once again, let's go back to what the objective is. If the objective is to kill cancer, then a couple more isn't going to matter. But if your objective is to get rid of your chronic pain and still go to work, 1 or 2 might make all the difference in the world. And the other thing is, you want to have repeatable and consistent responses with people so that they can go about having their regular lives. The vast majority of people don't want to come to a conference. They don't want to do it. They want someone to tell them exactly what to do, and that's what they want to do. You know, we want to think that people are more active in their medicine, but the truth is most people just want to take a pill and call you in the morning. So that's what we're trying to do, is to help them to do that, but not have to do it with pharmaceutical type cannabis or pharmaceuticals in general, but to be able to do it, it's like the best of both worlds. Yeah.
Hello. I want to ask, the first question will be about the solvents which you recommend for using for the extracts. Like you have mentioned some alcohol, I think.
Yes. Yeah.
And second one will be, what do you recommend for patients which are sick, which have prostate cancer or bone cancer in the skeleton metastasis? The combination of terpenoids, CBD or THC compression. Like what it should be? It should be 1-to-1. The combination of THC and CBD. Or 2-to-1, what do you recommend for these kind of patients?
And this was for bone cancer
and prostate.
Prostate.
Yeah, prostate.
Well, prostate cancer, let me see if I can go back there. Prostate cancer, interestingly, wrong direction, is one of the ID1 gene cancers. So the first thing I would do, I can't tell you an exact dose because there's a lot of other information I would need to know. But I can tell you that in that case, I would probably start out with a 1-to-1 or 1-to-2 ratio of THC to CBD with a much higher, I guess I'm going the wrong direction. It's stuck. Anyway, I can't get up there again. But so that's going to be, anytime you got the ID1, you can start by using a much higher CBD with a lower THC. If it doesn't work, I would try that for 1 scan cycle and then see how that works. And then for bone cancer, I believe you said, bone cancer, I'm going to go with the higher THC and a lower CBD. I'm going to do at least a 2-to-1 on that and see how that goes. Yeah. And as far as the solvents, I'm ethanol in all the way. I just, 190 ethanol, we've got beautiful extractions. I know some people might get higher THC levels, but at the expense of the rest of it, and it's also the expense of garbage in, garbage out. If you can't put it into your body on its own, don't put it into your medicine. It's kind of our theory. There have been studies that have shown that olive oil is an extremely good infusion. And then we also use MCT oil, which is the medium-chain triglycerides that you get from, we stay away from the palm oils, and we go with the coconut-derived MCT. And we'll make some CBD and THCA, especially THCA for the epilepsy patients. You have to be a little more careful because it's ketone effect. So it's very helpful to use the MCT for that. Okay. All right. Did it? Okay. Thank you.
Sorry, just one more question very quickly. Is there any value to industrial hemp CBD? Would you give it any importance? I mean, we're seeing a lot of CBD from industrial hemp. Does it have any medicinal value? Is it just are we going to see these companies in 2 years' time?
If somebody lives in the United States and they happen to be in a legal state, okay, and they're in California, let's say, where I am, and they have a choice between CBD derived from cannabis, sativa, or CBD derived from industrial hemp, there's not even a question. You're going to want to go with cannabis-derived CBD. But if somebody is in a place where they have no other options, as long as we know that there aren't heavy metals involved in the huge pesticides and that it's been extracted correctly, it's for serious illness, no. But if somebody just has for topicals and for foods and things like that, if they want to use it, it's fine. I think that industrial hemp is exactly that. Industrial, it's for textiles and fuel and fibers and building materials and all that. The fact that it has CBD in it is kind of beside the point. So ideally, you have to have the whole plant, including the THC, especially since most diseases are not effectively treated without a little bit of THC. So my preference would be that their industrial hemp would be used for industrial purposes and cannabis would be used for medicine.